So now we've checked under here. Where do we go to next? Does anyone have their pen light? Since we're doing the head and we've done here, why don't we go ahead and do the ears? So I'm looking to see that there's no tenderness on the ear, right? So you remember they taught you to lift the ear up and back and look inside. We're looking for any drainage, any wax, which is cerumen, right? So I didn't note any, so I would note if once I check this side, I'd go to this side. And please, you guys, don't lean over the patient like this. It's noted in that RHHT that the student lean over the patient, so you need to go to the other side. So you're going to pull it up, back, and there's no drainage, no cerumen noted in the ear. Okay? We would note that the ears are symmetrical. And then now we're going to go to the face. We're looking at her face. It's symmetrical. Okay? We're going to check the frontal sinuses. Remember the frontal sinuses here? If there any pain or tenderness noted in the ethmoid, remember the ethmoid? Okay? You all remember this? Okay? So there's no pain or tenderness, right? So now we're going to check, remember Perla? Okay, so I'm going to turn a little light off. Depending on your patient's, the color of their iris, sometimes if it's a darker color, like black or brown, you may not be able to see it very well. So you might have to dim the light or turn the blinds down just so you can be able to see it. But she has kind of grayish blue eyes, and so you shouldn't have any problem. So you never go to the patient's eye like this. What happens if you do that? What do you think might happen if someone puts a light in your eye? It could blind you temporarily. Okay, so you always want to come from the side, you can lift the patient's eyelid and come from the side. And what are you looking for?
Reaction,
What's the
dilation,
reaction?
constriction.
Has anyone ever seen that when you looked in the patient's eye? Do you really know? Okay, so some of you have, but has everybody seen pupillary constriction where the iris, not the iris, but the pupil constricts to a smaller? What if you have someone who just had a narcotic?
It's gonna be slower, or not
It
at
may
all.
be sluggish, okay? And you may have to really look to see if there's any constriction, because it may be already constricted, because what happens when you take a narcotic? It doesn't dilate it, cause it to constrict. Okay, so you do, once you've done the right side, then you do what? The left side. And so you're gonna come from the side, and you're gonna lift, and you're gonna bring it, and you're gonna see pupil constrict. So that's pupil, the P is for pupil, right? Equal. Are the pupils equal? You're gonna turn her around. You tell me, are they equal?
Yes.
Are they round? That's the R.
Yes.
Did they just react to light?
Yes.
Have we done accommodation?
No.
Okay, so have we met Perla yet?
No.
Okay, so you've done P, E, R, R, and L, but you have not done the A. Okay, so how do we do accommodation? So we're going to put the pen light in front of you here. I want you, if you don't explain it to the patient, they're not going to know what you want them to do. And just by putting this there, they're going to just try to be following you like this. You have to explain. So I'm going to put this pen light in front of you. Follow the pen light as I bring it into your nose, okay? What are we looking for? We're looking for conversion. Those eyes should come together. What happens if her eye goes this way and this one goes this way? She's got some nystagmus going on, right? Or it couldn't be some neurological something going on. We're not sure. We're not even advanced enough to truly know. But if we see that it's not conversion, we know that there's probably some nystagmus if one of those eyes start to go to the other direction. So I'm going to do it one more time. Follow the pen light as I come to your nose. And we're going to say she converged, and then did she accommodate? Did she go back to where her eyes originally said? So have we met Perla? Okay. So the P was for the pupil. E was that they were equal. R was that both are round. They reacted to light and accommodation. So have we met Perla?
Yes.
Okay. So that's that skill. Now, where do we go from gonna look at the, what, conjunctiva? What should it look like? Should be pink. The sclera should be white, okay? Now, if it's not white and it's kind of yellow, what's going on?
Jaundice,
There's some jaundice going on. So we think there may be some what involved?
liver failure,
Liver involvement. Whether it's liver failure or
cirrhosis.
whether this patient has been exposed to some chemicals that's caused some acute liver failure, or it could be chronic from alcohol abuse.
Alcoholism.
Okay, so if you got a patient that's alcoholic and he's got yellow eyes, then he's probably got chronic liver failure going on. Okay, so we've done the eyes. Where do we go from the eyes? To the nose. Always teach the students to put their hand here, lift the nose up, and look in the nair. And what are we looking for? We're looking for the mucous membranes. What should they be? What color should they be?
Pink.
They should be pink. However, they could be pale. They could be what else?
Dark.
Gray.
Crack. Dry.
As far as moisture-wise, they could be dry. They should be moist. However, they could be dry, right? Okay. And we're also checking for any occlusions, right? Why do we want to check for occlusions?
For breathing.
Breathing problems.
Yeah, if they're having some difficulty breathing, we want to know, well, if they wanted the nares, but also, what if you had to put an NG tube down? Which nair are you going to put it down? If my nair is occluded on the right and it's open on the left, which nair am I going to put the NG tube down? You're going to put it down the left. Why?
You won't go through on the right.
That's not necessarily true. It may be, you want to put it down the occluded side. Why?
So they still breathe.
So they can still breathe. You put it down the side that they only have to breathe on, they're gonna not be breathing, I assure you. You're gonna be calling the code. Now we've talked about the nair, but there's something else about the nose we should be assessing. The septum. Remember?
Oh, yeah.
You
It's
wanna
like
make sure that it's what?
It's in green.
Midline.
Straight, midline,
Okay?
deviated.
Make sure y'all writing this down. And if it's not midline, you would say it's what?
Deviated.
Deviated. Now, where do we go from the nose? The mouth. You see how by doing this step, you're not missing anything? Okay. So now we're going to have the patient, can you open your mouth for me and say ah? What are we looking for when she says ah? We're looking to see if that uvula or what? It's midline and rises, right? It could be deviated, However, hers is midline and it did rise when we said ah. But we're also looking to see her mucous membranes. What should they be? Pink and moist, but they could be something else. Based on what you're looking at, it could be pale looking, okay? And we're also looking at what else? What about the dentition? Any teeth? You're looking at the teeth. Are they healthy or not healthy? Please do not go in there and try to count every missing tooth and say, no, I got to count those teeth because I got to write 10 teeth missing on my paper. Just say multiple missing teeth if there's a lot, missing teeth, okay? The other thing, you're looking to see, the tongue. Is it pink and moist? Okay? So we are now done everything to here. What do we check after this?
The neck.
Okay, now we could, but it would be better if we go ahead and check the cranial nerves in the face. Okay? So what additional cranial? We've already checked cranial nerve 2. What additional cranial nerves? Remember, who was supposed to look up cranial nerves today?
I have the sheet.
Okay, so tell us what's cranial nerve number 3.
Ocular motor.
Okay, so let's check the ocular. Remember how to do that? I just want you all to do the H method. Most patients, especially elderly patients, it's very difficult for them to do that, where you do the cardinal fields of gaze and all of that. But if you do the H method, I like for you to follow my pen light with your eyes only. Do not move your head. You heard that last part? Do not move your head. If you don't tell them that, they're going to move their head. So follow the pen light with your eyes only. Now, I want you to see something here when I do this. Did you see her eyes, the muscle movement of her eye?
Mm-hmm.
That's what we're looking for. That tells me her EOM is intact. It's grossly intact, okay? Now, we checked the eye. What is cranial nerve number 4?
Trigeminal.
Okay. How do you do the trigeminal?
You get the cotton ball and touch their face
Okay.
or ask them to smile.
You asked her to smile because we don't have all of that equipment, so we're gonna use the one word smile. Can you smile for me? Can you frown? Some patients are not able to do that, and what could be going on if they're not able to smile or frown?
Previous.
They could have had a stroke. So if you're on a neuro floor and this patient's had a stroke, they may not be able to perform that skill. All right, number 5.
Number 5 is the abducens.
And what are you gonna do for the abducens?
It says lateral rectus movement of the eyeball also.
Okay, so we've
So we
already
already
done
did
that.
that, yeah.
And what about 6?
6, oh, the 6, sorry, that was 6. Yeah, 6 was the abducens and 5 was the trigeminal, so 7 is the facial.
Okay, so the facial. What do we do for the facial?
That's one,
Okay.
taste, facial movement, tension,
Okay.
and pauses.
So can you stick your tongue out for me? Side to side, up and down. Okay, put your tongue in your right cheek. Don't let me push it. Put your tongue in your left cheek. Don't let me push it. Okay, put some air in both cheeks. Don't let me push it out. Okay, you remember, you see that? Okay, now you're gonna have your patient, number 8.
Number 8,
Acoustic.
vestibulocochlear.
Okay, so that's hearing. Now, that was something I forgot to show you. When you are assessing your patient for hearing, one of the things you want to do, you want to, when you're over here and you're looking in your patient's ear, this is your opportunity to move this hand off the ear. Put this hand behind the ear. Do not touch their hair because then they'll feel it and think they're hearing it. And you're going to do this. And you're going to ask them, did you hear anything? Don't ask them, did you hear that? Because then that tells them there's something they're supposed to be listening for. Did you hear anything? And what are you going to, and you're going to tell me?
Yes.
What does it sound like?
Moving fingers.
Okay. All right, and then we know that they heard that. And then you're going to go to the other side and do the same thing. Do you hear anything?
Yes.
Okay, and what does it sound like?
Fingers moving.
Okay. Does that make sense? We could do the whisper test, but if you get that close to them, they know you're trying to do something. But if they don't know you're gonna rub those fingers, then you pretty much got a good response.
So, for a lot of the older patients, would it would be still normal for them not to be able to hear? 'Cause I did that on.
Because it could be because, as we age, our hearing starts to deteriorate. Some patients wear hearing aids, but they may not have it at the hospital. And if they are hard of hearing, you need to be able to tell us where they're hard of hearing at. Okay? So if you have your patient and they're hard of hearing in the right ear, you say cranial nerve number 8, hard of hearing in the right ear. And on the left side, you would say it's grossly intact if the patient could hear, right? Okay. Now, let's go back to the hearing. When we were doing the assessment here, and then we go to here. Is this a good time to check for jugular vein distension?
Mhm.
So there's 3 things you do. You look in, pull the ear up and look inside for any drainage or serum. Do the hearing test, and check for the jugular vein distension. Do it all at one time, then go to the other side. See how easy that is? Okay. Now, we've done everything to here. Now we're going to check the trachea. So we're going to check the trachea for what?
Symmetry, or not symmetry,
You
midline.
want to see that it's what? Midline. So you're going to have the patient, you can have the swallow test for the gag reflex. If the patient is able to swallow, they can swallow their own saliva, air, or you can have them drink water. But if it's contraindicated, please do not give your patient. If he's NPO, please do not give them something to drink. Okay? However, you're checking for the gag reflex. You're also checking for the trachea to see if it's midline. What if the trachea is deviated?
Could be.
They could have superior vena cava syndrome from a huge tumor in their chest. Okay? So, if you've never seen it before, so you just think your trachea is here, but what if it ends up over here?
That's wild.
They don't have long to live. I can assure you, if it becomes deviated, they're gonna be in a terrible state soon, okay? So now we've checked the trachea, it's midline, the gag reflex is intact. What cranial nerve can we check from after this point? What's that cranial nerve, ma'am? You know how to do the test, but what is it called? The accessory muscles, but it's also called cranial nerve number what? 11. So you're gonna tell, I want you to shrug my shoulders. I don't know why sometimes the students don't know the word is shrug. Okay, shrug. They'll say, can you move your shoulders? And like, okay, and then they can't understand why the patient not doing what they want. Shrug your shoulders. Shrug your shoulders up. I'm gonna push them down, don't let me push down. So if the patient is able to do that, is cranial nerve number 11 grossly intact? Yes, it is. All right, so at this point now, we're gonna take her arms, and we're gonna look to see that skin is warm. There's no bruises or lesions on it. It's dry. Can we check the skin turgor? Less than 3 seconds, right? If she was over 60, we check where else? The clavicle. Okay. We can check for capillary refill. You can always remember you're comparing one to the other. So we're checking capillary refill. It's less than 3 seconds. So we've checked the skin. We've checked the arms. We've checked the skin for skin turgor. We've checked the capillary refill. And we checked to make sure there's no bruising. However, I'm going to fake it like it's an IV here, okay? Oh my goodness, she has something here. Where's this location? What? But it's the brachial, but what else do they call this?
AC.
The antecubital or the AC, okay? And so we're gonna say she has a peripheral IV. It's in the left antecubital, and remember I told you guys you need to go look today, the colors and write them down, because sometimes the nurses do not write what they are on the IV site. They're color coded. Based on the color, it'll tell you if it's a 16, 18, 20, 22, or 24 gauge.
And is that universal?
Universal.
Okay.
Every hospital is the same thing.
Okay.
Okay. So this is her left AC, and we're gonna say she has a blue-green, which is a 22 gauge. And we're gonna look at the site. Here's the needle. It's going into the site. And we're gonna look at where it goes in at that site, and we're gonna say, is there any redness? Do you see any redness? Is there any swelling? Is there any pain when I touch it? If you can say no redness, no pain, no swelling at the site, then you can say no signs and symptoms of infection. But if there's one thing from those three, then you have to specifically say, if there's redness, then you'll say redness, but there's no swelling or no pain. But if all three meet that criteria, then you can say no signs and symptoms of infection. Do you all get that? Mm-hmm. Okay. Now, we're also addressing the dressing itself. Because if it's if it's coming off, but we're looking to see that it's clean, because you've seen some dirty dressings. Is it dry? Is it intact? But if it's not, you're going to say what's going on. Is the dressing coming off? Is it bloody? Is it leaking something from the dressing? You'll document that, because you want to be very clear. Because if Anna, in 10 years, the patient that you had 10 years ago decides to sue you for harm, you need to. I'll look you over this time. You need to be able to go back to your documentation and see that you documented well enough to cover yourself.
Sorry.
Oh, I'm sorry. I'm sorry. You need to be able to have some documentation that says, I did everything appropriately. This is happening to nurses today. They're not documenting appropriately, and what's happening, they're getting sued. You can get sued at any point, and they're getting sued, and then they don't have any documentation that reflects that. Okay? So now we just checked the IV site, but the IV site is not connected to anything. So what is it? It's saline locked, and that's how you'll document. So you're going to say the left AC, peripheral IV, number 22 gauge, dressing clean, dried, intact, the site, no signs and symptoms of filtration or infection, but we're also gonna say that it's saline locked. And so 10 years from now, I'm like, oh, she didn't have an IV when the patient is saying, no, I had IV. No, it's documented that she did not have an IV. There was nothing wrong with that IV based on this documentation. That's where we see nurses lose their license because they're not documenting, they're not documenting appropriately because they're task focused and they're not patient-centered focused. Okay? So now, where else could we have a peripheral IV? Could it be in the left dorsal hand, the wrist? Okay, so know your sites. But if you have a central lines go, where do they start at and where do they end up at?
Start here and then go to the aorta.
They will start here and go into the right atrium. That's a really serious site, you guys. So make sure you don't, when you're flushing those lines, there's no air in that syringe. Because if there's air in that syringe and you give them air embolism, it's all on you at that point. Okay? There's also a portacath. What are portacaths?
For chemo.
These
They're
are
like under the
invasive
skin,
lines
right?
that they don't go all the way into the aorta. However, they're implanted right under the skin. And when you're not using it, there's a power push needle that they place inside it when they need to use it, okay? And they usually numb the area and then they push, because it's kind of painful to push that needle through your skin. Your skin here is pretty thick, okay? However, when they don't use it, you just feel that little portacath under the skin, right? Don't get it confused with a pacemaker. Okay. So now you have the portacath, and you flush that. Now, what other things can you have? Could you have a PICC line? Where are PICC lines? Where do you normally see them? They're usually here, or you can see them here. Okay. Make sure you don't get them confused. Now, if you have an IV, peripheral IVs are usually just one lumen, but they may have two pigtails. But if you have a central line or a portacath or a Grosjean or a PICC line, they may be a single lumen, double lumen, or a triple lumen. When you have a patient that has more than one lumen, you need to be able to specify if this one is saline locked, maybe the other one is continuous infusion, and the other one is saline locked. So they depending on where the facility you're at and what they use, they usually come in colors. So maybe brown, blue, white, it could be purple, red, or yellow. So know when you're documenting, you have to specify what's going on with those three lumens. So if one lumen is connected to IV infusion continuously, and the other two are saline locked, you'll say yellow port with IV fluids, normal saline at 42 cc's an hour. The white and brown port are saline locked. Okay? Does that make sense? Is this the first time y'all hearing that? Okay. Well, good, because some of y'all that are getting ready to graduate, y'all need to know this. Okay? Now where do we go after we are checking the IV sites, everything is fine? Should we check for muscle strength of the upper? Okay. So squeeze my two fingers. Squeeze as hard as you can. All right, pull me to you, and then push me away from you. We just did three things. You know what those three things just told me? That this patient has good upper body strength. So we're assessing that on a value, and the value is 1 out of 5. 1 is meaning, or 0 meaning she's flaccid. 1 means if she can even move the arm. And then 2, 3, 4, 5. 5 is the best. So will we say she's 0 out of 5 or 5 out of 5? 5 out of 5. So that tells me that she should be able to pull herself up in that bed and help me if I need to pull her back up in that bed, right? Okay. So now we've done that. So where do we go from here?
Chest.
No, we'll go all the way past those lungs and heart. You wanna go to the lungs of the heart. It doesn't matter to me which one you do, okay? Can I borrow someone's stethoscope, and I'm gonna get some alcohol swabs.
I have a question. Remember the one where you have to, the cranial nerve that you have to do the smell?
I'm not, don't worry about that, because I don't want us knocking any patient out.
I didn't figure so, but I figured I'd
Okay.
ask.
There are some things that we're not gonna do just because I don't want, some of you all on those cardiac floors, and then you go pushing on that carotid and your patient end up in the ICU because you're like, I can't figure it out, and you're just going like this, and you don't know you cause this patient going arrhythmia. Once you become that nurse, you do everything you're supposed to do if you're working on that cardiac floor. Can I borrow someone's stethoscope? Okay, thank you. Now for me, doesn't matter if you start at the heart or lungs. I'm gonna start with the lungs just because it's easier for me. Okay, now please make sure you have your tips, earpieces. I had a student, he was so funny. He was in there and he had his
That would hurt.
stethoscope on, just listen to the lungs, didn't have a tip on here. I'm like, sir, how do you hear without an earpiece? And he kept doing this, because it was hurting him, because there's no earpiece on. But anyway, everybody has earpieces, right? So when you're assessing for the lung, there are 8 areas you should be assessing anteriorly and posteriorly, okay? When you're assessing anteriorly, you're comparing the left to the right, right? And you keep on, and then you go to the back. What if you have a patient that you can't, that's bedridden, or they just had abdominal surgery? How do you listen to the back of their lungs? Because they're in pain, you don't really want to have them pulled up because they may be in pain. How are you gonna get to listen to their lungs?
Roll them.
You can roll them, get someone to help you roll them to the side, or maybe when they get up that day, because maybe they're supposed to be getting up and ambulate, then you can listen to their lungs. So don't get frustrated if you can't get the anterior and the posterior done at the same time. As long as you make sure you get it done, maybe when they get up, or someone help you roll them over so you can listen to the posterior side. So you're gonna start, what are these airways?
Anterior.
What are these up here?
They already.
No, we're not talking about the heart, we're talking about the lungs. These are the upper airways, where the bronchus, remember all that? You're gonna hear bronchial sounds, isn't that you should hear, they should be loud, almost like wind, okay? So we're gonna start at the top. Deep breath in and out every time I put the stethoscope on your chest. Now, one thing I do want to mention, I do see students doing this. And before the patient can even finish taking, expiration, they're already over here. You have to hear a full inspiration and a full expiration before you move over, okay? Again. Okay, so we've just checked 8 areas. And so I checked one side, compared it to the other side. So anteriorly and bilaterally, all lung fields were clear, okay? However, if I heard some crackle somewhere, you're gonna document all lung fields were clear, except in which, on the right side, how many lobes do you have? Okay, and you have 2 on the left. So if it's the right lower lobe, you'd say in the right lower lobe you heard either fine crackles, coarse crackles. If you can't differentiate fine or coarse, I'm okay with that, as long as you knew that it was crackles, right? Okay. So then once you've done anteriorly, you're gonna go posteriorly, and you're gonna start up at those upper airways. so posteriorly and bilaterally, they were clear. So you could say anterior, posteriorly, and bilaterally, all lung fields are clear. Yes, ma'am.
Okay, what if you have a wound vac and you can't hear anything? Then how do you document that?
Okay, so if they have a wound vac, you can work around the wound vac unless it's the entire area.
Yeah.
You may not be able to assess that if the dressing is real thick.
I know they kind of have a belt on, and then they
You
have
know,
the.
even
after
if they
the
have an
surgery-
abdominal binder, you can you can undo the abdominal binder unless there's an order that say do not remove abdominal binder. You can undo it long enough to listen and then replace it back. Did you know that? Okay, the key is you gotta look to see what the order says. Can this be taken off? Because if the patient's getting up and shower, they're not showering with the binder. Okay?
Because I asked my nurse and he said that, oh, you won't be able to hear the lung sound because she has a.
Then you need to ask her, is it contraindicated if I open it up long enough to listen to it and I close it back? Okay? Because I guarantee you that the nurses are not doing it. But does that mean that it's right? You're going to see things in the hospital that you are going to be shocked to see. A nurse walks into a patient room on isolation with no PPE. And you're like,
Doctor did
no,
that
they told
yesterday.
me,
It was
doctor
wrong.
does it, nurse does it. Is it right?
Mm-mm.
But does it happen? At every hospital
Happened yesterday.
and all over the United States. That is how patients end up with VRE, MRSA, because what? We're the doctors are the biggest carriers of it because they are the biggest ones that carry that nosocomial infection around. Because how many doctors you see walk into that patient room, didn't even wash their hands, didn't even put a pair of gloves on and touch their wound?
Mm.
You're going to see it. It's okay if you say, hey, doctor, you want me to get you some gloves? Without saying, oh, no, you're not supposed to be walking in here without no gloves on. Just say, oh, doctor, I got you some gloves.
That happened
There's a way
yesterday.
to do things, right? To get things, to make sure that they're following things without being aggressive.
I'm like,
Okay, so we listened to the lungs anteriorly and posteriorly, they were clear. Okay, however, if there's something that's abnormal, you have to define where it's at. Yes, ma'am.
Did you do 6 on the back?
I did 8.
8.
Yes. I started with the upper airways, and then I worked my way down and then to the side. What usually happens to a patient who's had surgery and they have the lower bases, or what happens to those lower bases?
they get filled with fluid.
They may start to collapse, and what do you call that?
Atelectasis.
Atelectasis. So patient who's been in bed for several days, patients who's been to surgery, they're at risk for atelectasis. So what's important for them to occur when you come back?
Spirometry.
The incentive spirometer, getting them up out of the bed unless it's contraindicated, so they can expand those lungs. They start to run a fever, that's because that's what's happening. They're collapsing, and that bacteria is sitting there just brewing. And if you've had this patient for 2 days, and there's no documentation that you did the incentive spirometer, and the patient is ambulating, you're the one that has put this patient at risk because you haven't even done what a prudent nurse is supposed to do. And that ANA Practice Act, say prudent nurse this, prudent nurse that. Okay? I want to see y'all in peer review at your facility. All right, so we listen to the lungs. Now there's 5 areas on the chest where we should be listening to heart sounds. Where's the aortic? On what side?
The right.
Okay, it's the right sternal border. You want me to tell you how to find that? Because most students don't know how to find that. You remember this notch? Do y'all remember them teaching you about the notch right here? If you move it over to that little bone, there's like a bone that kind of sticks out.
The clavicle.
You're on that clavicle, and you move over there where that little, feels like a little, I guess a bone that kind of sticks out.
Yeah.
It is a bone,
Sticks
but
out the most.
kind of sticks out the most.
Yeah.
That's that sternal border right there. You come down over that bone into a valley. You feel the first valley? Then you go over another bone to the second valley. You're now in the right sternal border, second intercostal space. Do y'all get that? Okay? And that's where you put that stethoscope. So I'm going to find your sternal border. Right here. Down, over bone, because we are here in class and I can't literally pull up her shirt. However, if you're in the clinical setting, please do not listen to a patient's lungs on top of the gown. That is not the way you were taught. You should not be doing it. Even if you see the nurse and the physicians do it, that is not appropriate.
No
Okay?
question. Because I was asking that in a clinical last time, and they said that Methodist that's their standard policy.
Who?
Methodist.
Oh, but Methodist, they can do what they want to
Okay.
do. But as students, this is how you're taught. You're gonna see things, well, I don't believe what she said.
I was
or he
curious
said,
because I was trying to go in
because
there.
nobody teaches you, nobody is supposed to be listening on top of gown. What happens when you listen on top of stuff?
clothing and robe.
You're hearing, you
Rub
could think
and-
that's a rub, and it's not a rub, and it's just
The
the
gown.
sounds from the gown. Okay, so you should be listening directly on this again. So we found the sternal border, right sternal border, we're now in the second intercostal space, and now we're listening. And what should be the loudest? S2 should be the loudest. So now we've gone over to, now it should be, however, it could be that it's not, but you should be assessing it, right? So now, if you are able to figure out how to go over to the pulmonic, because pulmonic is on the left sternal border, second intercostal space. Some people can't get it over there, so they do that process again. They find the left sternal border, go down one, over another hump to the second, and then they listen. And then what should you hear the loudest? Okay, all right, so now we'll say we heard S2 the loudest, and now where do we go from there? Erb's Point. You know, Erb's Point is kind of right there, right there. Now, there are some female and men now, because we're getting a lot of obese men and women, and they have these pendulum breasts. Now, if you have a patient that has large breasts, then you will probably have to move the breast over to make sure that you get to that third intercostal space. How do you do that and feel comfortable and don't feel as though the patient may feel that you're being inappropriate?
You can ask them.
Always tell your patient what you're doing when you're doing this test. You always tell them, you know, I'm gonna move your breast over, or would you like to move your breast over for me so I can listen to it? You know, and then if they say, no, you can go ahead, I always get like a towel, or like if there's an extra pillowcase, or even if there's this.